We go on to our next speaker, Dr. Tushar Grover. Tushar Grover is again a medical director at Vision Eye Center, Delhi, and a senior consultant in cataract, cornea, and refractive services. And Tushar is now going to take us a little away from Smile for the moment. He is going to talk on phakic IOLs for keratoconus, friend or foe. So on to you, Dr. Tushar.
Thank you, ma'am. Very good evening, and thank you for having me here. So I'll be presenting the case as you said, and I'll call it when less is more, and it'll be clear why I say that. So starting out with the case scenario, this is essentially this is a 34-year-old male who's a known case of keratoconus, having advanced keratoconus in the right eye, mild in the left eye. This is stable keratoconus. So the individual has undergone C3R in the past and is stable now. Subsequent to the C3R, somewhere else, the patient had also undergone a toric ICL in the right eye, and this was 3 years ago. Now, these are the visual acuities. The right eye is 6/9 parts, which is not bad for somebody with this kind of keratoconus, but the individual is extremely unhappy, has significant uniocular double vision, ghosting, glares, halos, etc. Extremely unhappy with the vision. Now, when you look at the corneal topography, this is what it is. You can see it's a significantly decentered cone. You can see the cone sort of bisecting the visual axis here. When you look at the EKR map also here, you can see the histogram that's pretty widely spread out. The standard deviation is quite high, which again indicates across different zones, it's an irregular cornea. So not a great candidate for a toric ICL or any kind of toric IOL for that matter in this particular case. When we went ahead, did a scleral lens trial in him, there was a considerable amount of cylindrical over refraction and the vision was still not improving beyond 6/9. And with that cylinder incorporated, also the scleral lens was rotating and therefore was not stable. And the patient continued to be unhappy because we were not able to get rid of the symptoms for that patient. So it was a difficult decision and a difficult discussion to have, but the patient was more than happy with the possibility of getting the ICL explanted because the patient reported significant worsening of symptoms after the ICL was implanted. So this is the technique that I usually use to explant a phakic IOL, the two-hand technique where you use two blunt forceps, and the ICL was explanted quite atraumatically. As expected, the uncorrected vision did drop to 636. This is something you would expect. But when the scleral lens trial was done subsequently, you can see that the over refraction obviously is going to be very low. We were able to overcome the irregularities, and this time the patient's vision has improved to 6/6. So now the patient was extremely happy because though the uncorrected vision is lower, but the patient is much more comfortable with the vision with scleral lenses, and therefore subsequently no intervention was needed in this case, apart from the ICL explantation that was done. Now, the reason why I chose this case is that when you have a decentered cone like this is a slightly altered image just for demonstration and illustration. So when you have a decentered cone like this, it's important to always do a scleral lens trial or an RGP trial first. And if the patient's happy with vision from a scleral lens, then that's all that needs to be done. And if you do plan on doing a phakic IOL, it's important to either regularize the cornea first using a topo-guided PRK or centralize the centralize the keratoconus cone with an intracorneal ring. Thank you.
Thanks a lot, Tushar. In a decentered cone, if the patient's best corrected vision with glasses is good, then maybe you need not do a topo-guided regularization, and you could do a phakic IOL and get away with it. I think there were a lot of aberrations on the cornea of this particular patient. It is not just the decentered cone alone, of course, so that could be the issue. I would want others' thoughts on that. And the other thing is, the other question I have is, in an age-stabilized keratoconus, expert panel, would any of you consider doing a phakic IOL without doing cross-linking?
Very nice presentation, and I truly feel it brought about a good point that, in case the simple factor we go by is that if the patient is having good visual acuity with the spectacle correction, then going ahead and implanting a phakic intraocular lens makes sense, because what the phakic intraocular lens is something like the spectacles where it takes care of the lower order aberration, that is the sphere and the cylinder. But if he or she requires a contact lens, especially a rigid contact lens, a scleral contact lens, or a low-scale lens, obviously there's a significant amount of higher order aberrations, and the phakic lens is just going to make things worse. So that's a very, whether it's keratoconus or iatrogenic keratitis, that's something that we need to keep it in mind. And decentration is again we look for, that's in the posterior floor, where there's the nipple of the cone or the central 50% of the cone is within the central 3 millimeters. But even more important, we have put a phakic intraocular lens in some slightly decentered cones, not grossly decentered like was shown here. But in these cases, again, if the visual acuity is good with spectacles, then you can venture with phakic intraocular lenses. Otherwise, it's always, as was very nicely shown, centralizing it with the TGPRK or with a intact segment would be a good idea. And then 3 to 4 months later, we can place a phakic intraocular lens. As far as your second question about doing I think whether it's age or whether it's CXL which is stabilizing the cone, once it is very stable and it's been remained so for 2-3 years, then I think there's no harm in going and placing a phakic intraocular lens, especially if the patient is above 35 years of age or so. Of course, there's no scientific basis on my picking up this 35, but very rarely we come across, though it has been reported in the literature, that keratoconus progresses after that age.
So one thing definitely comes clear, Tushar, your talk was brilliant. Very important point came through that if there is aberrations on the cornea, these are clear-cut cases of scleral contact lenses and definitely not for phakic IOL, and explantation is the answer. But is there any nuance about the phakic IOL measurement details? Anything which you would want your company guys to know about these lenses? And what would it be different than in a normal phakic IOL implantation in normal eye? Dr. Sonu Goel?
So I think when you're planning for a phakic lens in these patients, and usually these patients would end up in toric phakic lenses, I would always go one size above the reading. So I would let the walt go a little up because I don't want these lenses to rotate. So a couple of patients that we have done post cross-linking, post intacts, and stabilized keratoconus, I think this technique works well, and I would always expect a walt beyond 750 in most of these patients, because stability for toric phakic lenses is a must in most of these patients, because most of these patients would then have rotations, and then you have to go one step up in these patients.
Actually, what I do believe is the central anterior chamber is going to be deeper in these keratoconic eyes as against the peripheral anterior chamber depth. So we have to mention both. And I would go for one size smaller in these eyes, because the central anterior chamber value is alone considered, then you might end up, the lens sizing would become big. So I would want to err to be a smaller lens so that I do not have a high walt.
But did you experience rotations in these patients with one size down?
I have only noticed an optic capture happening if the in a phakic IOL, if the company people have not factored in that this is a keratoconic eye and they have just taken into consideration the AC depth, which is deep in the center. Dr. Ramurthy, would you want to add anything? You need to unmute yourself.
I agree with you, Chitra. I mean, in the sense that, Sonu, we have done quite a few cases because there is a central steepening in the cornea. And if you say you get a 3.8, 3.9 millimeters of AC depth from the anterior surface of the lens to the back surface of the cornea, but in the periphery, it's quite shallow. So because of which there is peripheral crowding, and we find that there are cases where introduction of the lens itself becomes a little difficult, and on the table itself we have an optic capture. So what was suggested that was that you take measurements in the periphery of the anterior chamber and factor that in. But obviously there's no nomogram which takes into consideration the peripheral AC depth to determine the lens sizing. So what we have started doing is to go one step lower or 2 steps lower. In case of Indian lenses, it's 2 steps lower because they come in 0.25 millimeters. If it's an ICL, it's just 0.5 millimeters less. Your point is well taken. These patients are largely toric lenses, a significant amount of cylinder. Even small rotation may have a deleterious impact. But then we find that it works out well in our hands when we go a step lower.
So we've been doing star in most of these patients, and we have been following with the angle measurements as well. So a couple of cases that we have done, I think the wall usually we have figured out somewhere between 700 to 800, and the angles have been like grade 3 open in most of these patients. So I think we'll keep this concern also, and maybe angle measurements also. I think point well taken from Madam in these patients.
Shreyas, you want to add anything before we go on to our next speaker?
No, I mean, the same point. I mean, rarely, I think the optic capture does happen when you end up with a high volt, and that's usually the only problem. So ever since we started undersizing by one size smaller, especially when the Kmax is high. Obviously, if the Kmax is, within the normal range, that is just a steep cornea, 48 to 50, the ACD alteration will not be as much. But if you're doing a cornea with a 55 Kmax, the ACD alteration is likely to be higher. So at least in eyes which have a higher Kmax, look at undersizing the lens by one size.
So thanks, Tushar. It was a wonderful presentation.